Here we'll learn about the events of the menstrual cycle and clinical terms used to describe common phenomena. The physiological details of hormone regulation can be found in our notes. To begin, write that the menstrual cycle comprises the events of the ovarian and uterine cycles, and that the ovarian cycle drives the events of the uterine cycle. Uterine bleeding, menstruation, or a period, marks the beginning of a new menstrual cycle. Let's show this with a quick table. Show that the ovarian cycle, which tracks the events in the ovaries, comprises two phases. The first phase is the follicular phase. This is when ovarian follicles mature and a dominant follicle emerges to prepare for ovulation. Show that the follicular phase ends with ovulation, in which the follicle bursts and expels the ova from the ovary. The second phase is the luteal phase. This begins after ovulation and is when the remaining dominant follicular tissues become the corpus luteum. Then indicate that the uterine cycle, which tracks the events in the uterus, comprises three phases that align with the ovarian cycle as follows. The first phase is marked by menstruation. This is when the uterus sheds its lining. It syncs up with the follicular phase of the ovarian cycle. The second phase is the proliferative phase, which is when the endometrium begins the process of rebuilding itself and grows thicker. It continues through the follicular phase. The third phase is the secretory phase, which is when the endometrium becomes rich in glandular tissue and reaches maximal thickness in preparation for implantation of the embryo. This corresponds with the luteal phase of the ovarian cycle. If conception and implantation do not occur, menses begins and the cycle starts again. Now let's learn some details about the menstrual cycle that are important for predicting and regulating fertility. As we do so, we'll create a larger, more detailed diagram of the menstrual cycle, so go ahead and outline the ovarian and uterine cycles. Now indicate that menstrual cycles between and within individuals are highly variable. Most cycles are between 23 and 35 days. So the commonly accepted 28-day cycle is based on averages, not on the most common cycle lengths, and we should not assume a patient has 28-day cycles. Furthermore, intra-individual variation, the variation within one person's cycle lengths, is approximately 5 days. So, for example, a woman might have cycle lengths of 23 days, 25 days, or 28 days, and this would all be normal. Variation among and within an individual's cycle length is due to several factors: age, BMI, population ethnicity, lifestyle, and stress levels. As we'll see, cycles within the first year or so after menarche, the onset of menstrual cycles, tend to be longer, whereas the cycles during the perimenopausal years tend to be shorter. Menstrual bleeding duration and volume are also variable, indicate that the mean duration is 4 days, plus or minus a day and a half. In addition to blood, menstrual fluid also comprises cervical mucus, vaginal secretions, and endometrial tissue. Blood loss during normal menstruation ranges from 5 to 80 mLs, with an average of approximately 30. Now let's add the phases of the menstrual cycle into our diagram. We'll start with the ovarian cycle on the outside. Show that the follicular phase lasts approximately 17 days in an idealized 29-day cycle. During this time, a dominant ovarian follicle develops. Then show that ovulation, the ejection of the ova from the ovary, marks the end of the follicular phase and the beginning of the luteal phase. Notice that ovulation does not exactly occur midway through the cycle, nor is it always 14 days before the onset of menses. This variability has important implications for fertility predictions. Indicate that the luteal phase lasts roughly 12 and a half days. During this time, the corpus luteum forms from the remaining cells of the dominant follicle and produces progesterone. Next, layer in the details of the uterine cycle. First, show that menstruation initiates a new uterine cycle and lasts roughly 4 days. Menstruation expels the ova along with the uterine lining and other components of the menstrual flow. Menstruation is followed by the proliferative phase, in which the uterine lining starts to rebuild. Recall that after ovulation, the corpus luteum produces progesterone. This hormonal shift triggers the secretory phase of the uterine cycle, in preparation for implantation of a potential embryo. In the absence of conception and implantation, progesterone levels fall and the secretory phase ends with the onset of a new menstrual cycle. Ovulation is necessary for conception, but may not always occur even in healthy women. And our notes indicate that up to 12% of cycles in healthy, normally cycling individuals are anovulatory, meaning that an egg is not released from the ovary. Anovulation can be caused by a variety of physiological or pathological factors, including stress, pregnancy, hypothalamic pituitary disorders, and the use of combined hormonal contraceptives which block ovulation. Ovulatory status, of course, is important for those who wish to become pregnant or avoid pregnancy. However, natural variability in the lengths of the follicular and luteal phases makes it nearly impossible to predict the timing of ovulation based on dates alone. This is why the so-called calendar method is an unreliable form of birth control. Indicate that more reliable signs of ovulation include changes in basal body temperature, which falls right before ovulation and spikes in the luteal phase, changes in hormones, especially luteinizing hormone, which triggers ovulation, and changes in the cervical mucus, which becomes slippery. It's often compared to an egg white. These changes may be subtle and do not always mean that ovulation has actually occurred, but they can be helpful indicators for patients who are trying to time intercourse to increase the likelihood of pregnancy. However, transvaginal ultrasound is a more definitive way to see that ovulation has occurred. Return to our diagram now and show the fertile window, which is approximately the 6-day window when intercourse can lead to pregnancy. It includes the 5 days preceding ovulation and the day of ovulation itself. This window is set by the lifespans of sperm cells and ova. Sexual intercourse in the days preceding and following the fertile window are unlikely to lead to pregnancy. Now let's address conception and loss. Up to half of all fertilized eggs do not implant into the uterus and are expelled in the menstrual fluid. Of those embryos that do implant, more than 20% are spontaneously aborted, often before the pregnancy is clinically recognized. These spontaneous abortions are most often due to genetic abnormalities that are incompatible with life. Before we move on to clinical terms, let's summarize changes in the reproductive functioning during the lifespan. At one end of the line, indicate that menarche, the onset of the first menses, occurs between the ages of 10 and 16. At the other end, indicate menopause, the cessation of menstrual cycle, occurs roughly between 45 to 55 years. Then indicate that at these extreme ends, individuals are more likely to experience irregular cycles and higher anovulatory rates. After menarche, irregularity lasts for about 12 to 18 months, and the perimenopausal period lasts around 4 years. Although pregnancy is less likely to occur when the cycles are irregular and anovulatory rates are higher, it's not impossible, and patients should definitely be advised to use contraceptives if sexually active. Indicate that peak reproductive years last from about 18 months post-menarche to the perimenopausal period. Once again, remind ourselves that the intra-individual cycle length varies by roughly 5 days and up to 12% of cycles are anovulatory. Now let's learn some clinical terms to describe problems with menstruation. First, indicate that abnormal uterine bleeding is defined as irregularities in frequency, regularity, duration, or volume of menstrual bleeding. Heavy menstrual bleeding is defined as blood loss of 80 mLs or more, or simply as blood loss that negatively affects a patient's quality of life. Intermenstrual bleeding, which is another form of abnormal uterine bleeding, is uterine bleeding between defined menstrual cycles. It can occur for a variety of reasons, including hormonal changes, trauma, infection, fibroids, polyps, or even cancer. Next, indicate that amenorrhea is the absence of menses. It can be primary or secondary. Primary amenorrhea is the absence of menarche and menses by the age of 16, most often due to genetic abnormalities or hypothalamic pituitary deficiencies. Secondary amenorrhea is the absence of menstruation after menarche. In other words, the cessation of menstruation in someone who has been having menstrual cycles. It's associated with such things as pregnancy and breastfeeding, physical, nutritional, or psychological stress, some contraceptives, polycystic ovary syndrome, and ovarian failure. Finally, indicate that dysmenorrhea is characterized by severe, sometimes debilitating, pelvic abdominal pain during menstruation. Pain may be accompanied by nausea, diarrhea, and fatigue. It can be primary or secondary. Primary dysmenorrhea is pain during menstruation caused by uterine contractions, which are induced by prostaglandins. Secondary dysmenorrhea is pain during menstruation caused by underlying disorders, including endometriosis, fibroids, or polyps. In regards to pain management, NSAIDs are helpful for some patients, but for others, hormonal contraceptives that limit endometrial growth and therefore prostaglandin production are a better option. This concludes our diagram.